Welcome to the weekly neurology deep dive. I am your host, and today we are jumping into a topic that I suspect keeps many of us up at night. It is often called the great masquerader of our field.
Absolutely. It is incredibly rare, certainly, but it is one of those few conditions where missing the diagnosis is, well, it is a genuine tragedy because it is treatable.
Exactly. Today we are analyzing a new systematic review on central nervous system Whipple's disease. And before we get too far, I should mention this deep dive is produced by Amer Gavnini. Amer Gavnini always does a fantastic job putting these together for us.
He certainly does, and it is a pleasure to be here. Before we proceed into the data, we must state clearly that this production is for educational purposes only. There is absolutely no commercial goal involved here.
Precisely. We were just providing a summary of the data, and we strongly recommend that you, the listeners, go and read the full paper yourselves to get all the nuances.
I agree. So let us introduce the paper we are dissecting today. The title is Movement Disorders and Oculomotor Abnormalities in Whipple's Disease, an updated systematic review. It was authored by Erikos Maslias and colleagues.
And this was published in the journal Tremor and Other Hyperkinetic Movements in 2025, so it is very recent.
Yes, and this paper is significant because it updates the data from a previous review conducted back in 2018. It examines the cases reported between 2017 and 2025, which provides us with the most modern snapshot of the neurological phenotype of this disease.
So for the busy neurologists who might be listening to this between patient rounds, let us start with a practical executive summary. What are the absolute headlines you need to know from this review?
Well, the first headline is that central nervous system Whipple's disease is rare, but the diagnosis is chronically delayed, often by years.
A delay we want to avoid.
Exactly. Second, supranuclear gaze palsy is the most common sign. It is present in about 58% of cases, and it usually starts with vertical gaze. Third, the pathognomonic sign, oculomasticatory myorhythmia, is actually more common than we previously thought. It appears in about 25% of patients.
Which is a huge red flag if you see it in the clinic.
Absolutely. Fourth, and this is perhaps the most critical pitfall, a normal duodenal biopsy does not rule out central nervous system involvement. The sensitivity there is only about 50 to 60%.
We will definitely dig into that.
Yes. And finally, for diagnosis, cerebrospinal fluid polymerase chain reaction is a highly useful trade-off between invasiveness and yield, sitting at about 71% sensitivity. And for treatment, the trend is shifting toward oral regimens involving doxycycline and hydroxychloroquine.
That point about the duodenal biopsy sensitivity is frankly alarming, and we are going to tear into that during the diagnostic section. But let us look at the scope of the paper first. The mission was to analyze 168 patients with central nervous system Whipple's disease, who presented specifically with movement disorders or oculomotor abnormalities.
Yes, 168 patients is a robust number for such a rare condition. And the demographic profile they found is remarkably consistent. We were looking predominantly at men, who make up about 78% of the cohort.
And the age of onset?
The mean age of onset is roughly 50 years, but the diagnostic delay is it is the most concerning aspect of the demographics. The median duration of symptoms before a diagnosis is reached is approximately 2 years.
2 years. I mean, that is a substantial amount of time for a treatable bacterial infection to just be replicating inside the central nervous system.
It is devastating. And part of the reason for that delay is how we are taught to recognize the disease. We typically associate Whipple's disease with systemic symptoms.
Exactly. We look for the malabsorption, the severe diarrhea, or the profound weight loss. Does that classic clinical picture hold up in this specific neurological cohort?
It does, but with a massive caveat. Weight loss was present in about 48% of patients. Arthritis was seen in about 38%, and gastrointestinal issues in about 41%.
So while those numbers are significant, it implies the opposite is also true.
Correct. It means that a significant portion of patients, potentially half of them, may present with isolated neurological symptoms without any of the classic systemic signs.
So if a neurologist is waiting for their patient with a movement disorder to develop diarrhea or significant weight loss before suspecting Whipple's,
they're going to miss the diagnosis entirely. You simply cannot wait for the gut symptoms to appear.
that is a crucial reframing for daily clinical practice. If we cannot rely on the gut, we must rely on our neurological examination. So let us analyze those neurological signs, starting with the eyes. The paper identifies oculomotor abnormalities as a major red flag.
They are a massive red flag. Supranuclear gaze palsy is the most prevalent sign across the board. It was found in about 58% of the patients.
And it typically affects the vertical gaze first, correct?
Yes, vertical gaze was the first to go in about 48% of the total cohort, and it is very important here to distinguish this from a nuclear or a nerve palsy.
Because in a supranuclear palsy, the vestibulo-ocular reflex is preserved.
Exactly. If you perform the oculocephalic maneuver in the clinic, the eyes will move fully. That proves the final common pathway is intact and the lesion is higher up.
Does the palsy usually remain isolated to just the vertical gaze?
No, over time it very often evolves to involve horizontal gaze as well. Furthermore, it is rarely an isolated finding. In the vast majority of cases, the gaze palsy is accompanied by other movement disorders or significant cognitive impairment.
Aside from the gaze palsy, were there any other ocular signs noted in this updated review that we should be looking for?
There were. Pendular nystagmus, often of the Virgin's type, was noted frequently. But a particularly interesting finding in this 2025 update is the prevalence of uveitis. It was noted in about 5% of cases.
About 5%. That seems higher than what we used to think.
It is an increase from previous historical reports. It strongly suggests that ophthalmologists have an important role to play in early detection. If a patient with unexplained uveitis begins to develop neurological symptoms, that should immediately trigger a suspicion of Whipple's disease.
That is a great clinical pearl. Let us move on to the movement disorders themselves. This paper discusses what they call the hyperkinetic spectrum, and the term myorhythmia appears constantly in this context.
Yes, and we must be extremely precise with our terminology here because it matters for diagnosis. Myorhythmia was present in about 40% of cases, but we must clearly differentiate myorhythmia from myokymia.
Because they sound similar but represent entirely different localizations.
Precisely. Myokymia refers to that worm-like rippling of muscles, which is of peripheral origin. Myorhythmia, which is what we see in Whipple's, is a rhythmic myoclonus. It typically beats at 1 to 4 hertz, and it is strictly of central origin.
And within that central category of myorhythmia, we have the famous pathognomonic signs, the oculomasticatory myorhythmia and the oculofacioskeletal myorhythmia.
These are the classic textbook hallmarks. Oculomasticatory myorhythmia involves a rhythmic convergence of the eyes that is perfectly synchronous with contractions of the masticatory muscles.
So it presents as a rhythmic chewing motion coupled with the eyes converging and diverging.
Yes, and this paper found these pathognomonic signs in about 25% of cases.
Wow. I mean, that is significantly higher than the 8 to 20% that was previously reported in older literature.
It is, and it implies that if you observe this specific sign in your clinic, the diagnosis is highly, highly probable. But importantly, its absence certainly does not rule out the condition.
Because 75% of patients will not have it. Now, aside from myorhythmia, ataxia was also a major finding in this cohort.
Ataxia is just as common as myorhythmia. It affected about 40% of the patients in the review. It can be axial or appendicular. In fact, severe gait and balance issues were reported in about 46% of patients.
Therefore, a patient presenting with progressive ataxia and a vertical gaze palsy is a prime candidate for this diagnosis.
Absolutely. They need to be worked up for it immediately.
What about other movement disorders? Things like Parkinsonism or tremor? Do those occur?
They do occur, but they are much less common. Parkinsonism, dystonia, chorea, and tremor each occurred in under 10% of cases. They are certainly part of the differential, but they are not the dominant features you will see in the vast majority of patients.
So based on all these findings, the authors suggest a clinical tetrad, a pattern recognition tool for neurologists. Let us break down the components of this proposed tetrad.
The proposed pattern is the specific combination of 4 elements. 1, supranuclear gaze palsy, specifically affecting the vertical plane. 2, movement disorders, specifically myorhythmia or ataxia.
And the third element.
3 is cognitive impairment, which was actually present in about 69% of patients. And 4 is sleep disturbances, found in about 40% of patients.
So vertical supranuclear gaze palsy, myorhythmia or ataxia, cognitive impairment, and sleep disturbances. If a clinician observes that specific combination, the suspicion for central nervous system Whipple's disease should be extremely high.
It should be at the very top of your list.
Let us talk about the differential diagnosis, because that combination of vertical gaze palsy, cognitive issues, and falls naturally leads most neurologists straight to progressive supranuclear palsy. How do we differentiate them clinically at the bedside?
It can be challenging early on, but there are vital nuances in the exam. In Whipple's disease, patients often preserve the full range of voluntary vertical movements much better than patients with progressive supranuclear palsy.
So their smooth pursuit is often intact.
Yes, smooth pursuit is often intact in Whipple's, whereas it is impaired quite early in progressive supranuclear palsy. Furthermore, square wave jerks, which are very common in progressive supranuclear palsy, are typically completely absent in Whipple's disease.
And naturally, if you see the oculomasticatory myorhythmia, that effectively rules out progressive supranuclear palsy.
Correct. Another challenging differential mentioned in the paper is anti-Iglon 5 disease.
Yes, that is a newer entity that has been gaining a lot of attention.
And it shares several features with Whipple's, including sleep dysfunction, supranuclear gaze palsy, and bulbar symptoms. Interestingly, facioskeletal myorhythmia can actually occur in both conditions.
So in that scenario, the bedside clinical phenomenology might simply not be sufficient.
Exactly. You will require serology for the anti-Iglon 5 antibody, along with specific testing for Whipple's to truly distinguish them.
That brings us perfectly to the diagnostic investigations. If we suspect Whipple's based on the tetrad, we have to prove it. Let us start with imaging. What does the MRI actually show us?
The MRI is abnormal in about 87% of cases. However, the findings are incredibly nonspecific. You might observe some T2 hyperintensities or general atrophy. Contrast enhancement was seen in about 24% of cases.
So it does not give you a definitive answer.
No. The most critical takeaway here is that a completely normal MRI does not exclude the disease. You simply cannot rely on imaging alone to rule it out if the clinical suspicion is high.
Which leads us to the most significant diagnostic pitfall discussed in the entire paper, the duodenal biopsy. For decades, this was considered the absolute gold standard screening tool.
And this is a paramount point for daily clinical practice. Countless neurologists assume that the gastroenterologist performs a duodenal biopsy and it is negative. The patient definitively does not have Whipple's.
We are practically conditioned to think that way.
We are, but this paper reinforces that this assumption is fundamentally incorrect. Periodic acid shift staining of the gut is positive in only about 52% of central nervous system cases.
Only about 52%, so it is barely better than a coin toss.
It is a coin toss. And even if you upgrade to polymerase chain reaction of the gut tissue, it is positive in only about 58% of these neurological cases.
That is staggering. The gut is clearly not the reliable tissue for confirming central nervous system involvement.
Not at all. If your clinical suspicion is high based on the neurological exam and the gut biopsy comes back negative, you cannot stop there. You must investigate further.
So where should we look next? Cerebrospinal fluid seems like the most logical next step for a neurologist.
It absolutely is. Polymerase chain reaction of the cerebrospinal fluid was positive in about 71% of cases.
That is much better.
It is. However, you must specify the polymerase chain reaction test. If you just ask for periodic acid shift staining of the fluid, it is positive in only about 37% of cases.
So standard staining of the fluid is virtually useless.
Correct. You must order the cerebrospinal fluid polymerase chain reaction testing specifically. It represents the best overall trade-off we have between invasiveness and diagnostic yield.
And what if the cerebrospinal fluid is also negative, but the patient fits the clinical tetrad perfectly? They have the gaze palsy, the ataxia, the cognitive decline.
Then you must be persistent. The paper suggests testing other sites, such as saliva or stool, or simply repeating the cerebrospinal fluid analysis after a short interval.
And if all else fails?
In the most difficult refractory diagnostic cases, a brain biopsy may be necessary. Brain biopsy obviously has the highest yield, with periodic acid shift staining being positive in about 95% of cases.
But obviously that is a highly invasive procedure.
Yes, it carries significant risks and is strictly reserved for when all other less invasive methods fail and the patient is deteriorating.
Let us transition to treatment. This is a bacterial infection caused by Tropheryma whipplei, so antibiotics are the answer. What has been the standard regimen?
Historically, the traditional regimen has been intravenous ceftriaxone, followed by a long course of oral trimethoprim sulfamethoxazole. This combination was used in about 70% of the historical cases reviewed in this paper.
But there have been growing concerns about that approach, correct?
Yes, there have been significant concerns regarding treatment failure and clinical relapse with this regimen. This is possibly due to inadequate central nervous system penetration by the drugs, or perhaps emerging bacterial resistance.
So the paper notes an emerging trend toward a different, newer regimen.
Indeed, there is a major shift toward using doxycycline combined with hydroxychloroquine. And importantly, this is an all-oral regimen from day one. Its usage has increased significantly across the globe in recent years.
Is there trial data supporting this shift?
Yes, the paper heavily references a trial by Moose and colleagues which suggests that this all-oral regimen is non-inferior to the traditional intravenous ceftriaxone followed by trimethoprim sulfamethoxazole.
That is a massive development for clinical practice. An all-oral regimen would certainly be vastly easier to administer and manage, especially for patients in an outpatient setting or those who cannot tolerate long-term intravenous access. What about the actual clinical outcomes? Does the antibiotic treatment actually reverse the profound neurological deficits we discussed, like the gaze palsy and the myorhythmia?
The data shows that measurable improvement in the movement disorders was observed in about 53% of cases.
About half.
Yes. While that number is encouraging for a disease that is otherwise fatal, it is certainly not a guarantee of full recovery. However, the data clearly shows that early initiation of antibiotics strongly correlates with much better neurological recovery.
Which emphasizes exactly why we need to bypass the gut biopsy delays and diagnose this as quickly as possible.
Precisely, because despite treatment, mortality remains tragically high at about 25% in the reviewed cohort.
And even when they survive and improve, we also have to watch out for the immune reconstitution inflammatory syndrome, correct?
We do, and the ever-present risk of relapse. These patients require careful, continuous, long-term monitoring. You cannot simply treat them with a course of antibiotics and discharge them from your clinic.
Because the immune system waking up can cause its own damage.
Exactly. The immune response can sometimes dramatically worsen the neurological symptoms initially, which then requires careful steroid management to control the inflammation without letting the bacteria run rampant again.
This has been an incredibly comprehensive review of the 2025 update. Let us summarize the practical takeaways once more for our listeners so they can take this straight to the clinic.
I strongly suggest 3 main takeaways. The first is to maintain a high index of suspicion. You must suspect central nervous system Whipple's disease in patients presenting with vertical supranuclear gaze palsy, myorhythmia or ataxia, cognitive changes, and sleep issues. Do not wait for the systemic gastrointestinal symptoms to appear.
Because in nearly half the patients, they never will. And the second takeaway concerns the diagnostic trap.
Do not rely solely on gastrointestinal symptoms or duodenal biopsy results to rule this out. The sensitivity is simply too low for neurological cases. Cerebrospinal fluid polymerase chain reaction should be your preferred first-line specific test.
And the third takeaway regarding the physical exam.
Remember that the pathognomonic oculomasticatory myorhythmia is present in a full 1/4 of these patients. If you see that rhythmic chewing and eye convergence, the diagnosis is highly likely, and you should act on it.
Excellent. Finally, we like to end with a provocative thought, something for you, the listener, to mull over.
I would ask you to consider the broader implications of the oral-only treatment regimen of doxycycline and hydroxychloroquine. If this truly becomes the established standard of care, could it significantly lower the barrier to early empiric treatment in ambiguous cases?
That is a fascinating point, because if the cerebrospinal fluid is negative and a brain biopsy is deemed too risky.
Exactly. We are naturally hesitant to start a patient on long-term intravenous antibiotics without definitive proof, but a relatively safe oral regimen might completely change that risk-benefit calculus. We might start treating suspected cases much earlier, even when the diagnostic workup remains frustratingly inconclusive.
That is a critical consideration for those complex cases where time is of the essence. We would like to thank you for listening to this deep dive into the Great Masquerader.
Thank you for having me.
We will catch you next week on the Weekly Neurology Deep Dive.
Yeah.